Welcome. I'm Tamara Rosen, Assistant Editor for Becker's Hospital Review. Thank you for joining our webinar today titled A New Reality, Controlling Costs in Your Cath Lab and Preparing for Cardiac Bundled Payments with Analytics. With the shift from fee-for-service to value-based care, controlling spend on your high-value supplies is becoming even more critical. The combination of automation and data analytics has the power to change behavior and drive new insights. Joining us for the presentation today are two thought leaders from Cardinal Health. Dr. Peter Mallow, Director of Health Economics, Outcomes Research and Reimbursement, and Jeff Perukansky, Director of Trusted Advisement for Operations and Services of the Cardinal Health Inventory Management Solutions Division. Pete and Jeff will be discussing the regulatory and operational challenges to managing your cath lab inventory and controlling costs, and how hospitals are leveraging RFID automation and data to gain alignment on critical purchasing decisions to drive down costs and product variability. Before we begin, we would like to remind you that the presentation will be sent to all registrants within a week of the webinar. We will also have time for Q&A following today's presentation. You can type any questions you have in your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to answer as many questions as we can during the time we have for Q&A, and we'll follow up with you directly via email to answer questions we did not have time to address. And now it's my pleasure to turn the program over to Pete to kick off today's webinar.
Thank you, Tamara. It is a pleasure to be here. Jeff and I want to thank Becker's Hospital Review for hosting us. As a health economist and outcomes researcher, I spend my days buried in data. And yes, I enjoy that. However, I have to make sure I am asking two questions all the time. And that is, first, are we looking at timely and accurate data? And second, is that data capable of producing evidence-based insights? I'm joined today by my colleague Jeff, who works with our customers doing just that, answering those two questions to ensure that we have timely and accurate data and can use that data to inform how we operate in our cath labs by combining radio frequency ID technology and the power of advanced analytics. I'd like to take a moment to talk about the agenda today. And first, I'm going to introduce some of the challenges around reimbursement and regulatory environment that we're facing, and that is putting pressure on our cath lab to think differently and look for solutions that can solve those challenges. I'll turn the conversation over to Jeff, who will talk more about how RFID can help you accurately manage, track, and monitor high-value procedural inventory. We'll conclude with a case study and a few parting thoughts before turning it over to the Q&A. I would be remiss if I did not introduce Cardinal Health. We are a Fortune 500 company. Many of you on this line are our customers, and we want to thank you. We work with over 4,000 leading healthcare institutions across the world, and we've been blessed to be recognized by Gartner's for the past 5 years as a leader in transforming the healthcare value chain. From our perspective, we all bring a passion to delivering healthcare and enabling the business of healthcare for our customers so you can focus on what matters most, and that is your patients. What is that challenge we're facing? It is that our reimbursements are at risk. We know that. We've seen that in our cath labs for the past several years. We've heard the term value-based payment. We might have heard other synonyms such as fee for value, pay for performance, episodic payment models, alternative payment models. I can go on and on and on. However, they are all recognizing that we are under a paradigm shift from a fee-for-service world that we used to be in to one that is worried about paying for outcomes, quality, and at the same time reducing costs. That triple aim that we hear so much about. The cath lab is under great scrutiny. Why? Quite simple, patient volume and costs of those procedures, both of which are extremely high and only increasing. As such, many of the programs that CMS has proposed are addressing the cath lab in terms of what we can do to achieve the triple aim. I want to take a moment to talk about one such program that was released this summer, and that is the Episodic payment model for cardiac care. Now, I must say it is a proposed rule, and the final rule is expected to come out in the near future, and changes may be great or may be minimum. We won't know until it comes out. It is a 900-page rule, and I'm not going to bore you by reading all 900 pages to you, but I do want to highlight a few points that are salient for our conversation today. First, if you are in one of the selected 98 metropolitan statistical areas, it will be a mandatory program for your coronary artery bypass graft patients, your CABG patients, and all of your acute myocardial infarction patients, your AMI patients, whether they're treated medically or whether they're treated through a percutaneous coronary intervention. CMS will set a target price for you, and if you come underneath that target price, you will get to keep those extra dollars. If you come above, you will have to pay CMS back. In that program, we expect, or I should say CMS expects, to save $170 million over the 5-year pilot. Now, we don't know what those target prices are. We don't know what those MSAs are, but we do know that we should be evaluating our systems, processes, and protocols to prepare for this episodic payment model. Not only will we have to worry about the index visit or hospitalization, but we're going to have to worry about the 90 days of care afterwards under this proposed model. As such, readmissions and extended or unexpected post-acute care is going to be critical to our success around that target price. And understanding what supplies that we use or don't use during that index admission will be critical to achieving those outcomes. Where does all this fit? It's hard to say as things continually to evolve, but over the last several years, as we've adopted more value-based programs such as ACOs, accountable care organizations, and the bundled payment care initiatives, we can expect these to continue to roll out over the next several additional years, to the point that by 2018, 50% of all payments from CMS will be tied to value. And what does this mean in aggregate? A recent HFMA report suggests that there will be a $460 billion in declining payments to providers. CMS will be shifting this risk onto you to manage and achieve the triple aim that we hear so much about. $460 billion, that's a big number to wrap your head around. And I'd like to pull out maybe a smaller number. That's 2 hours that your physicians are spending each week complying with the reimbursement and regulatory burdens placed on these programs. That's above and beyond all of the paperwork that they typically and normally do for their patient care. That's above and beyond their actual patient care. I can only imagine what the rest of your staff in your Cath Lab is doing to comply with all of these administrative burdens. And as a matter of fact, when I thought about that and I looked a little bit deeper, I found a recent report that suggested $15 billion in lost productivity in hospitals complying with the administrative burden associated with these reimbursement and regulatory models. I've spent a few minutes talking about the reimbursement side, and I would like to take a moment to not neglect the regulatory demands, because at the same time these new reimbursement models for value-based payment are coming out, we still have our existing regulatory demands. And those include hospital quality reporting, readmission penalties, Medicare Never events, and several others that I can keep going on. But I do want to highlight, for those that have physicians employed, MACRA begins January 1st, 2017. And let's not forget about the burden of switching over to the ICD-10 system. A year ago, we adopted that, which required all of your hospitals to completely redo their coding systems to accommodate 9 times, or about 186,000 codes in a completely new structure format, and make sure that you're reporting these accurately to CMS and your other payers. Just this past month, CMS introduced 4,000 new ICD-10 codes, of which 90% apply to the Cath Lab. This is a growing administrative burden as all of these programs are rolling out very fast, to the point that we often are now hearing stories about physician and staff burnout, as well as shortages of trying to apply the care. And as we think about that and move forward into the value-based environment, I would suggest that it's very important that we put provider satisfaction at that same level of the triple aim and move to the quadruple aim, if you will. I did not invent this term. It's been around for a couple years in the literature. But the basic premise is that if we're going to adopt new solutions to achieve improved patient outcomes, lower costs, and higher qualities, we have to put the clinical and non-clinical staff at that same level if we're going to be successful. And as we continue our conversation today, I want to open up a poll question for us to consider around how we can think about the quadruple aim. Our first poll question is, with respect to patient care, what is the main challenge or barrier you are experiencing with inventory management in your Cath Lab? I'll read the answers. Manual processes, dealing with expired, obsolete, or recalled products, product standardization, or all of the above. We'll give a couple minutes, or a couple seconds, I should say, for people to respond, and then we'll talk about the results. Thank you for your responses. We can see that over 80% suggested manual responses or all of the above. And that's a great segue to my colleague, Jeff, who will talk more about how RFID combined with advanced analytics may be a solution for your consideration.
Thanks, Pete. We've just heard Pete talk about the regulatory and reimbursement challenges with CMS's continued shift towards value-based care. Our goal continues to be cutting waste out of our inventory. So what's next? You're probably asking yourself, Jeff, how do I do that? Or, great, Jeff, we've been trying to reduce inventory for years in our procedural areas, but we just can't get over that next step or that next hump. We all know collaboration is essential to this inventory reduction. However, it's not just with doctors anymore. We've got to look at it throughout the supply chain. Data enables different partnerships with our vendors, our manufacturers, our hospital and IDN leadership to drive those outcomes Pete talked about while keeping costs down. Data drives our supply management decisions to a proactive approach versus a reactive approach. Data helps us focus the clinical staff time on the right supply chain activities. Imagine doctors and clinicians spending time on value analysis work versus those 2 hours Pete talked about around the administrative burden and chasing supplies down. We can start to control cost by leveraging data and not emotional or feeling stocking strategies. And data can help us maximize tools like consignment, the capitated pricing, and bulk buys that we all try to execute. In addition, that data can help identify ways that clinicians and the supply chain can collaborate on standardization of physician preference items. Leveraging an inventory management solution such as RFID, barcode, or Kanban that will integrate with EMR and materials management information systems, hospitals, distributors, and manufacturers will help eliminate those barriers to controlling cost and give your team the right information for predictive planning to achieve this end-to-end visibility that's so important. The ability to collaborate is an important aspect of the way we support value-based care. Another one of those components is frankly transparency. Transparency and this end-to-end visibility are crucial for driving quality controlling your costs, and managing the satisfaction across the enterprise. This end-to-end visibility provides help across your health systems with compliance with UDI regulations and tracking. That cost per procedure by doctor, by manufacturer, looking at your consigned and owned inventory across not just one hospital, but all of your locations. We all know how difficult it can be to have these discussions around usage or cost without data, or even worse, with circumstantial data. This visibility arms you with the right data to be collaborative. It also helps support patient safety initiatives. It gives you high visibility and availability of products needed for patient care. It helps you optimize clinical workflow, again, removing those clinicians from supply chain related activities. And it also helps prevent expired and recalled products. This system-wide transparency and this end-to-end visibility help reduce that administrative burden that you're facing today. And we believe automation that drives this end-to-end visibility and leads to analytics is the key to controlling those costs, key to reducing the inventory in the Cath Lab. So let's take a moment and see how you're managing your inventory today. So that brings us to our second poll question. We're going to do an audience poll, and I'll give you the question and the answers here. The question is, how is your facility currently managing that high-cost Cath Lab inventory? And you've got 4 choices. The first is manual, barcode, RFID, or unsure. We'll take a few seconds here and let everyone respond, and then we'll cover the results. Awesome. Thanks for responding. I see that we've got a very high percentage of manual and barcode, which is what we expected to see, frankly. And it's why we're here today. It's to talk about how we can make that shift off the administrative burden, because the 43% and the 41% really are an administrative burden on not just your supply chain, but also your clinicians. We've looked at various types of supply automation solutions, and RFID, or radio frequency identification, is a clear winner for that complex environment in your Cath Lab. So let's get back to that quadruple aim that Pete talked about. I've asked some questions in the beginning of my slides around how do we reduce inventory in our procedural areas, or the administrative burden is just too great on my clinicians or physicians to make this dream of a reduced inventory become a reality. The ability to know whether you're delivering the right quality of care at the right cost really depends on properly documenting and coding that Pete talked about. Imagine if, at the point of use, your staff could actually see the accumulating cost of a case in real time as they use supplies on a patient. It's like going to the grocery store and watching your bill add up every time something you're purchasing goes across that scanner. We've known this data actually builds awareness for our clinicians and physicians around expense that's flowing through the Cath Lab, just like it builds awareness around your weekly grocery bill. We're now able to take that data, perform analytics, and present it in a timely and meaningful way that can truly impact the behavior of our clinicians. With RFID, the product is waved in front of a workstation reader, the charge is captured from the RFID tag, and documented with an interface to your hemodynamic system. I want to take a break here and talk shortly about a quick story. I was on site with a customer a few weeks ago, and I was called to the Cath Lab basically because the doc and the Cath Lab director believed that the price of a product they saw on the screen was actually incorrect. They thought it was overinflated by a few $100s. After researching the item, I found the price was actually correct. So I went back up to the Cath Lab, and I spoke with the doctor who happened to still be there and the director, and let him know that, no, that is in fact the price of the product. The doctor was appalled that that is how much that product cost. He actually instructed the director to immediately change his preferences to use a different product that was well better priced and better positioned and offered the same standard of care. This real-time data made an impactful and meaningful decision on patient care and controlling cost in the Cath Lab.
Jeff, that's a great story about working across the silos that often exist within the hospital setting to use data timely and accurately to make decisions and evidence-based insights. We know under the episodic payment model, CMS expects that an AMI case with the 90 days post-care factored in will cost about $24,000, of which $12,000 of that comes from the indexed hospitalization, and supply costs alone can easily eat 40 to 60% of that cost. So as we think about how we're going to adopt processes and standards with respect to this episodic payment model, knowing exactly what supplies contribute to our outcomes and the cost of our case is critical knowledge for success.
Thanks, Pete. It is critical for our customers to be able to track and have visibility to high dollar supplies. And in addition, we've got to make great use of analytical tools to drive that collaboration across the supply chain for making decisions about your Cath Lab inventory. We just talked about data and how you can use that data to have different types of conversations at a macro or system level. So let's take a look how we enable that. Online tools like the dashboards you're seeing now and point of view stations in the room, as you heard about in the last story, can be a springboard for conversations and can help you easily conduct a deep, granular analysis of your cost per case to aid in these conversations. Data analytics are helping our customers drive operational improvements every day. They're also controlling cost through the utilization of dashboards and reports that give us critical alerts to products at risk and provide smart ordering capabilities. At any given moment, our customers know the total value of the inventory, not just in one hospital, but in all hospitals across their system. These analytics also drive utilization by supplier or product type. They reveal utilization by case type and procedure area and individual physician. This is critical as you prepare for bundled payments and value-based care. Analytics provide enterprise visibility and expiration management. Not only will you have a thorough itemization of the total cost, you'll also reveal new opportunities to reduce variability and improve efficiency by identifying outliers such as rebate agreements. These analytics can uncover powerful insights that can help you control cost, reveal savings opportunities that you may not have considered before, help you avoid stockouts, more on that later, and increase efficiency and productivity as we prevent expired, obsolete, and recalled items. Let's take a closer look at some of the tools that can better help you control costs. We all know how difficult it can be to have conversations around a cost per case or how much a doc is spending on a case. The right type of data with advanced analytics and automated inventory management will drive better visibility for our customers around cost per case and helping them prepare for CMS bundled payments. Let's be honest, this data can actually help you speak the same language as your clinicians and really drive evidence-based decisions. In addition, by continually tracking and collecting this information and looking at it from product receipt in your facilities all the way to use on a patient, you can gain real-time visibility of the objective data across your health system that you need to facilitate discussions with your physicians and share how those costs can be impacted with value-based payments. I understand that this comparative cost data can be very sensitive, and it's some of the most compelling data we have available for driving change and standardization. Being able to provide physicians with product pricing information before, during, and after a procedure can open their eyes to the way that one product can significantly impact the total cost of care. All right, so let's look at a case study of how an IDN changed the game with controlling their cost and managing their inventory. Here you can see how Emory St. Joseph's revitalized their Cath Lab operations and drove automation and analytics with an RFID solution. In helping them effectively manage more than $2.5 million in inventory and monitoring over 2,000 SKUs in their 7 cardiac catheterization labs and 3 electrophysiology labs. Cardinal Health's RFID solution in the first 18 to 24 months helped Emory St. Joe steadily shrink their inventory to match actual utilization. This was not a focused PAR optimization effort that immediately dropped inventory up to a level that physicians were uncomfortable with. The system reduced their inventory and helped them improve their inventory management and created prospective reports for products due to expire in the near future, which allowed them to share information with their product reps so that it could be swapped out or replaced. In addition, it also allowed them to not have those conversations anymore, to be able to move product around within their facilities before it expired. The system also improved their revenue capture by over $300,000. The Cardinal Health RFID system integrates with their charting and documentation systems, which has dramatically cut down on the manual entries and charge capture errors that again increased that administrative burden. Emory St. Joseph's is just one of the many hospitals who've benefited from this solution. We're happy to send out another case study after this webinar for those of you who are interested in reading more about the great clinical, financial, and operational results that have been achieved. So what's missing in your Cath Lab? With more data comes more visibility and frankly more insights. Based on the RFID solution and a barcode tracking technology, mobile apps, and cloud-based analytics software, hospitals can monitor their high-value PPI products all the way from manufacturing to the point of care. Just imagine what this visibility is able to do for you. Help you optimize your inventory levels, lower your cost, streamline your workflow, and provide new insights to improve performance. Automated RFID inventory management and analytics also have the power to help hospital leaders better predict those trends and analyze product utilization at every touch point throughout your enterprise. As we've discussed, analytics can help you accurately document, accurately capture charges, and accurately provide information around unique device identifiers to help you track and report implantables for registries and meaningful use stage 3 while streamlining your audit process. Again, technology also helps you ensure you have the right amount of data or inventory on hand. This is something that's understated but important. It's very difficult to have conversations with your clinicians about reducing inventory when the perception is that they never have the inventory they need to take care of a patient. And this leads to that emotional stocking strategy I talked about earlier in the presentation. The power of analytics to assist in maintaining accurate inventory levels and controlling cost will also provide your teams with more time to address other critical needs in the lab versus stopping a case to try to find product or call a rep to get something brought in. Armed with a robust RFID inventory management platform that's interfaced to your legacy systems, for the first time you can drill down through data to take evidence-based actions to optimize and align inventory with clinical use in your Cath Lab. The time is now to prepare for Medicaid bundled payments and value-based care. Arm your team with the tools and data they need to drive lower cost, increase clinicians' time spent with patients, and drive better satisfaction.
Thank you, Jeff. We'll conclude with just a few thoughts on how you can prepare for value-based care in the coming cardiac episodic payment model. It starts with understanding where you're at today. We saw from the poll questions that we rely heavily on manual processes and barcode technology, and we have several different challenges that affect our ability to deliver the care that we want to our patients. So as we better understand that current state, we can now build the vision. And I offered a new way, perhaps for many of you, to think about that vision, and that is the quadruple aim, to build a strategy around how do we not only achieve lower costs, higher quality care, better outcomes, but improving our provider satisfaction. And as you drive that strategy, the next critical step is aligning the goals and incentives across the organization to do that. And it starts with having timely and accurate data that is understood and transparent across all of the stakeholders that need to be bought in to delivering the highest quality care that you can. From there, you can roll that strategy out and those incentives throughout your organization and drive the adoption of data standards, product standards, and processes and other systems to improve your Cath Lab operations. And of course, once it's in place and working, it's time to roll it out through expanded reporting and automation to make life just a little bit easier for all those involved. No one organization has all of the answers. However, partnering with organizations like Cardinal Health that has the clinical and supply chain experience to help you assess your Cath Lab systems and processes is a critical first step in accelerating your ability to achieve the quadruple aim. I'm going to turn the conversation or the webinar back over to Tamara so we can address some of your questions and hopefully provide answers to those that we can today. Thank you very much for your participation.
Thank you, Pete and Jeff, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for, and as a reminder, the Cardinal Health team will follow up with you directly via email to answer any questions we do not get to. The first audience question we have here is, it says, I understand the Medicare episode payment will be a phased implementation. Can you elaborate on this? Pete, I think I'll steer this one to you.
Absolutely. Thank you, Tamara. As I mentioned, I don't have time to go through all 900 pages, and I did leave out the fact that we're going to be rolling out the cardiac episodic payment model. In the first couple years, it's about data collecting, and it's about understanding how we're doing during those performance years. And as we move forward to year 2020 and 2021, the rewards and the penalties will plateau at 20%. So as you can see, 20% deviation off of that $24,000 potential target price is a lot of money and can greatly impact the bottom line of your Cath Lab. So as we're thinking about those processes and systems, we can build in the phased implementation of the episodic payment model, but we know the end goal is very significant.
Thank you. And as a follow-up question to that, another audience member asked, under the episode payment model, will hospitals receive quality-adjusted target payments for each episode of care?
Yes, they will. Those target prices that are yet to be set will factor in based on the DRG, the diagnosis-related group, but as well as a number of quality factors, such as mortality, that CMS has proposed. I don't want to speculate what the final rule will say, but we can be sure that quality metrics will impact that target price. And we know based on the CJR, the bundled payment model for hips and knees, that the target price is going to be a factor of both national and regional data from your local metropolitan statistical area. So as those prices are revealed to us in the final rule, we'll have much better information to plan for how to improve our systems and processes accordingly.
Wonderful. Thanks for explaining that. Another audience member would like to know, you mentioned that the products have an RFID tag. Does each product need to have one, and how long does it take to tag those products?
And thanks for the question. The best practice, or what we recommend, is to tag high-value products that have a value of $50 or more. This is where it's critical to have that accuracy and visibility needed to gather the data that helps make evidence-based decisions. Anything less, we'd recommend using a two-bin Kanban or a barcoding system for tracking those products. The entire tag and registration process only takes a matter of seconds. Really what happens is all the information is kind of placed on the RFID tag at the point of registration. Some vendors will actually register or pre-tag before that product gets to your facility. If the product doesn't come in pre-tagged, this step to affix the tag would occur in your facilities, and really only takes a few seconds to do and register. Typically, we see materials management handle this task as they scan the manufacturer barcode to pull in all product data, including the manufacturer, the reference number, the size of the product, the lot and expiration, as well as the serial number. The data is then captured and associated with that unique RFID tag, and the tag is placed on the product. Simply then, it's a matter of placing it into inventory and then using that tag to scan in front of a reader as it's used on the patient. So again, best practice, $50 or more. The time to tag is very minimal, and in some cases, vendors will actually tag before the product's delivered to your facility.
Great, thanks for clarifying that. Another audience member would like to know, how exactly does charge capture work in your system?
That's a great question. I visit a lot of hospitals, and I often hear that they're having tremendous problem with their documentation and charge capture. Again, it goes back to that administrative burden. When something's not documented correctly or when it's not captured correctly, there's a lot of rework that goes into both the back end and then understanding exactly how things were used in the procedure. With our automated RFID system, your clinicians will have a point of use device in the room or a point of use reader in the room that will actually capture the product and the right charge information at the time the product is used on the patient, simply by waving it in front of the reader. It's really a seamless process for that clinical staff. And once that tag is waved, it's scanned directly into your documentation and your hemodynamic systems. This way, the clinical staff can actually focus on patient care versus making sure that everything is documented correctly in the system. And again, it does eliminate those documentation and charge capture errors.
Thank you. It looks like we have time for one more question. So our last question of the webinar today is, how does this system help optimize my PAR levels? And does this change the way I'd work with product reps on consignment?
I think because the system tracks actual usage patterns in real time, it continually optimizes PAR levels and improves your reordering points automatically. So it really does an ongoing PAR optimization that I think most people talked about they're doing by hand or manually, or potentially using a barcode system for. It then triggers a reorder and suggests the appropriate PAR levels based on the analytics and trend patterns as you're actually utilizing the product. Again, as we talked about before, this piece can help avoid those stockouts. It can also help avoid emotional overstocking, where we've all had it happen. We've had a patient on the table and we haven't had the product necessary for the right standard of care. So what do? We go out and order more product, and just to make sure that it's on the shelf. So the power of this data actually analyzes all of those usage patterns in the Cath Lab, along with trending data, your expiration reports, and it allows us to be more proactive and take action with our product reps to right-size our inventory and our ordering. Again, this is another way that we're getting to end-to-end visibility and partnering with the right individuals to actually cut waste out, or again, being able to exchange and receive credit for those products that are about to expire.
Okay, that is all the time we have for today. I want to thank Pete and Jeff for their excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.